Good afternoon or good morning, depending on what time zone you're in. Welcome to Preventive Medicine Grand Rounds for September 7th, 2022. My name is Antonio Neri from the Division of Scientific Education and Professional Development at the Centers for Disease Control and Prevention. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship, along with the Health Resources and Services Administration, Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the Epidemic Intelligence Service at CDC or have equivalent public health experience. I wanted to note that we'll start our host site application here soon for PMRF. So if you're a host site who's interested in doing so, please check out our website, cdc.gov/prevmed, for more information about eligibility and application. It should start here October. Note that we use Zoom for the audio and presentation and the question box to pose questions during this Preventive Medicine Grand Rounds. You can pose questions via the question box at any point during the lecture, and the speakers will work on answering them at their discretion. Note your name may appear associated with the question you posed. If you do not want your name to be associated with the question, please check the Submit Anonymously box. Continuing education credits are available for the live course up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDC PMRF. Again, CDC PMRF, all capital letters. You can also find the course code on our website, cdc.gov/prevmed. If you have any questions, please contact myself or email the program at prevmed@cdc.gov. Please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the U.S. government. We'll take our usual moment of silence for our colleagues, friends, and families who've dedicated their time, energy, and sometimes lives fighting the COVID-19 pandemic. Okay. Today's Grand Rounds will be entitled Vocal Biomarkers as Predictive Analytics Tools for Community Health Screening, presented by Henry O'Connell. The presentation will be approximately 1 hour with 30 minutes for questions and answers afterward. Please welcome our presenter. Take it away, Henry. The floor is yours.
Thank you. Thank you so much, Tony. I appreciate it. We will spend some time together talking a bit about vocal biomarkers and their use in predictive analytics and for screening in community health. We invite any questions that you would have, and please feel free to post those. We're going to try to answer them as we can during the talk, or we'll have time at the end of the talk to do so. I wanted to begin by talking a little bit about speech and the history in the field, as well as some of the foundational work that led us to where we are today. Speech production is one of the most complex and rapid motor behaviors. I try to reference articles. If one looks at vocal biomarkers in relative to healthcare, you'll find that the research is rich in the field. And I would encourage you to reach out and take a look at that. I think it'll be helpful. We utilize speech from a very early age to communicate a range of feelings, emotions, thoughts. We communicate in written as well as spoken speech, but spoken speech requires the coordination of many of our functions of our body. And because of that, it carries with it a lot of information about a range of different functions in the body, including the central nervous system, musculature associated with the lungs, the larynx, the mouth. All of this is evident in speech, and particularly in speech that changes longitudinally across. One of the things that we see every year during flu season is changes in individual speech because of of congestion or blockage in our larynx or other places. And because of that, we're capable of recognizing things. COPD, for instance, is something that is evident in speech, but so is diseases like Parkinson's, Alzheimer's, a range of different diseases, Huntington's disease. But we also see measurable changes in individuals when their anxiety or stress or depression increases. And these are very interesting things to be able to monitor using voice as a non-invasive tool, which we can do on smart devices or on web or using communications and such as this. Speech companies, because of the tools that have developed over the last number of years, can analyze millions of data points a minute. In fact, Canary Speech looks at approximately 12.6 million data points every minute. We're actually looking at a 20 millisecond window, and we slide that window 10 milliseconds across an audio. The time it takes us to analyze that is of say 20 seconds, 30 seconds of speech, which might represent 6 million different data points, is measured in milliseconds of time. And so you can see often real-time return. So the technology of today really does afford us the opportunity, using machine learning and deep neural nets. We can apply those technologies to analyze speech in near real time, in seconds of time, and provide effective tools to augment the data set that we may have to analyze or address or make judgments concerning an individual. And this is true of individuals and also of populations. Let me talk a little bit about the tools. We often, in the industry, we throw around terms like deep neural net or deep learning. But deep neural nets are really a tool that has been developed over the last 15 years that provide an ability to measure complex data sets and to draw inferences about relationships of those data sets with the individual that they were gathered from. And deep neural nets are a very sophisticated mathematical modeling process, but it happens on the web. It can happen in milliseconds of time. So when one sets up a deep neural net, in this particular arena, we're looking for what is called composition, which is in speech, the measurement of human condition and disease. Deep learning uses machine learning for the development of algorithms that can then be used, once they're developed, to measure. Those algorithms can be used to measure different functions, both in our health and human conditions, such as mood or stress, but they mimic how our brain is functioning and working. So they're not as good as our brain. Our brain is superior, but nonetheless, they mimic that. So when a doctor is sitting with a patient and they're interviewing a patient about a particular condition, the doctor's knowledge of that condition is broader than the answers provided them by the patient often. They understand sometimes elements that are not specifically components of the spoken word. If you're talking with an older patient, for instance, and you ask them how they're doing, it's not uncommon for them to say, "I'm doing fine." But you might hear in their answer that they may be anxious, or they may be sad, or they may be depressed. And that allows the physician during that conversation to explore that with the patient. The tools that we are making and have made can provide that information on remote devices. And that can facilitate the conversation that a clinical team member is having with someone. In Japan right now, we're utilizing this technology in their annual health checkup. So annually, the Japanese government does an annual health call to about 30 million individuals. They engage them in several questions about their general health, about their cognitive health, depression, anxiety, how they're sleeping, a range of different questions. During that conversation, we can listen to the spoken word, even though it's in Japanese. We're listening to that spoken word and we're analyzing for anxiety, depression, and cognitive health, and providing that information as an augmented data set for the team that are doing these calls. This is important. So we're using artificial intelligence, machine learning, artificial neural networks, and deep neural networks. And all of this then provides us with the capacity to create a data set that's based on characters, these 12.5 million characters a minute, which are sublanguage. All right. So the wonderful thing about tools like this in today's technology capabilities is that they're quite scalable. We currently are capable of handling tens of millions of interactions a month. The requirements in our Japanese effort would require annually listening to conversations and providing information over 30 million of those. It's non-invasive. It's conversation. We ask individuals a prompt to reply to a question or to look at a picture and tell us what they see. This gives the individual the opportunity to use multiple functions of their brain and therefore evaluate multiple functions of their brain. This can be done within the restrictions and requirements and the guidance of medical data records, and Canary speech functions within those. So we handle data at the same level of security and confidentiality that it's handled in any large medical institution in our country or across populations. We're currently functioning in Japan and Europe and here. So the technology offers the same confidence for data security and medical data records management that you would have if you went in to have an in-office or a clinical checkup. It's very cost effective. We analyze the data in milliseconds. We can return scores either to a medical data record or to a patient's medical record or to the clinician while they're talking with the patient to help guide that conversation. It's very useful in remote patient monitoring or in population monitoring. So it can be applied in a range of areas. It can be applied confidentially and non-invasively, and it's very scalable technology. This just gives you kind of a timeline. So if you think about it, we use both video conferencing as well as smart devices and telephone medical data records or telephone data systems to engage with an individual. During that engagement, we look for 20 seconds of speech. 20 seconds doesn't have to be contiguous. It can be 10 seconds here and 5 seconds there. And it's accumulating that over time. And once it has enough to function with, it then does an analysis on it. But generally 20 seconds of time from a prompt. Tell me how you're doing today, or tell me about your trip to work, or how is your morning going? That type of conversation. That vocal sample is then analyzed using speech engines and the technology platform that we have, which has been developed over the last 6 years. It's transferred over APIs that are secure, and they're medical data record audited and the same type of APIs that any medical center would use. We then score that in less than 3 seconds and return that score. A report can go directly back to the screen where a conversation is ongoing. And in fact, we do this with some of the large providers. Microsoft Teams for healthcare, for instance, has Canary speech integrated into it now. It's a product that will be available during the next couple of months. But this entire stretch of time between when you collect audio, the engagement with the patient might be three minutes of time. We're currently doing a study with Beth Israel and Harvard on Huntington's disease. The engagement in clinic with the patients on a tablet was approximately 5 to 8 minutes total time. It allowed them to have patient engagement through conversation with the patient, and then Canary Speech identified over 1,100 biomarkers in speech that correlate and relate to the longitudinal development of that disease over time. Speech, just another comment about both the complexity and yet the simplicity in which we use it. I checked on Google a couple of days ago just to look at it. I often would say, you know, Amazon, for instance, the Echo product interfaces with about 130 different languages. Today, there are over 7,000 languages that are spoken or known of. And some of them, population size is quite small, and some of them are quite large. But Canary Speech's approach is to analyze sublanguage features of speech. And because of that, our transition from a depression, anxiety assessment in English to Japanese was easier path for us. Speech's complexity lies in its tremendous uniqueness. We perform it nearly effortlessly as a child, but it's a very highly complex sensor motor skill. It depends on habitual, that's automatic. I mean, we have terms for, you know, foot and mouth type of thing, because often we're not trailing what we're saying in our mind. We're actually speaking ahead of time, but it engages our respiratory system, our larynx, our vocal cords, the musculature around that, our cheeks, our tongue, everything that we would consider our articulatory muscles in our face. Very complex. Any illness or damage to any components of that can cause changes in the underlying bio features and biomarkers in that, and those are traceable. Using the technology we have, it's sensitive and selective to that. I just wanted to talk a little bit about this. If this is 1.6 seconds of speech across, if you look at the smallest square in the larger complex of squares, that's approximately 20 milliseconds. It's a little larger than that, actually. We're capturing in that 20 milliseconds over 2,500 data points. We then move that forward 10 milliseconds and do the same slice. We're capable of capturing thousands of features and vectors across a second, in fact, 12.5 million of them. So the complexity of the data is perfectly matched at this time with the tool set we're using. Machine learning, deep neural nets, they were built to analyze data like that. They're capable of doing so in milliseconds of time. That allows us to actually provide a tool that can be effective in the time frame in which we're speaking to the person and help guide the conversation. I wanted to just take a look at this kind of simplified way of looking at speech. Over the last 35 to 40 years, speech has developed. There was a time 35 years ago when the only mechanical way of understanding speech was if I said yes or I said no. And today we're capable of actually listening to multiple voices at a time and accurately creating a text from those voices. Caption call, for instance, that we engage with so that we can broaden the reach and engage more people in a conversation like this is a result of that technology. So having speech recognition, automatic speech recognition, is an outgrowth of natural language processing. Speech to text is an outgrowth of that. Speaker ID or voice prints is an adjunct to those things. But then recognizing word and word phrasing and having an understanding of what that phrasing means can give us an idea of what an individual may be engaging with. Some of the very earliest examination of Alzheimer's patients was work done by MIT looking at Agatha Christie's rich source of printed text, 40 years of novels. They were able to discern from that breadth of text that Agatha Christie in onset of Alzheimer's began within a certain period of time. They could see it in that novel. And as she progressed over time, her Alzheimer's got worse, and there was evidence in the size of the words she was using, the complexity of her language skill was deteriorating over time. That provided some of the foundational information that speech could in fact identify conditions, human condition and disease in voice. The use of text is limited to some degree because not all of us have the same level of education that Agatha Christie does. And the example I like to give is Agatha Christie's capabilities were extremely advanced with respect to the use of language and her vocabulary. And as she developed Alzheimer's disease, it deteriorated. Well, my capabilities are not Agatha's. And as she developed Alzheimer's disease, she came to a level where she's maybe equivalent to where I am. She had advanced Alzheimer's and I don't. So while it was foundational work in the space and it can still contribute to the accuracy of models, the use of sub-language characters where you're looking at 12.5 million data points and matching that so nicely with deep neural nets and deep learning provided an ability to advance the reach of this technology in a more meaningful way, I think, in the analysis of both human conditions and disease. So it's just a wonderful advancement where you're following the science and the technology growth. Just real positive. Now, word phase analysis and spoken word understanding. You can say today to an Alexa product a whole range of different things. Your children can even order things you don't want occasionally. I consider that a little humorous, but it does happen. But you can talk about wanting to know what your prescriptions are, or you can speak to Alexa and she understands the meaning of what you're saying well enough to be able to respond in very accurate ways. Over in the last box, speech classification is the term given to the area of the analysis of human condition and disease, as I have spoken about before. That sits on the foundational efforts of many individuals in the technology advancement, matching it with our capabilities provided to us by people like Azure and AWS and other organizations, where the processing time has come down so dramatically, and the capacity of machine learning deep neural nets have expanded so dramatically. So those things coming together have created the opportunity a few years ago, about 5 years ago, as deep neural nets and deep learning were coming out, to really move forward. There have been some other advancements recently that have augmented that effort. It's a very exciting field. Vocal biomarker evaluation. I wanted to talk specifically about anxiety and depression and some work we're doing here. One of our chief scientists, Nam-Hee Kwong, has worked with and has presented a paper that has been accepted, and I'm going to relate to some of that. This particular work was conducted on a call center data set. Now, call center data is generally 8 kilohertz. Our smartphones are 16 kilohertz. Both data sets, while different, model very nicely for identifying things like anxiety, depression, Alzheimer's, Parkinson's, and others. It does require that you train you train the model specific to the data set. And there are some overlap, but your highest specificity and accuracy come from training them independently. So neural networks neural network models identify common voice biomarkers. So think about it in kind of a simple way. Imagine an audio comes into a server, either Azure or AWS or others around the world, and we're implemented across Europe, Asia, and here. But imagine a data trail, an audio comes in. In our system, it goes through machine learning and a stack of feature extraction. It passes through the feature extraction to this 12.5 million data sets in a minute. Those features then can go into deep learning and deep neural nets, and a correlation, a mathematical correlation of those features with an individual's known condition can be created. You're selecting specific features out of that a range of 12.5 million. You're selecting certain features, which then can be built into an algorithm. That algorithm can be used for scoring the severity of a disease quite specifically and sensitively across time. So now you not only have a tool to measure in real time what an individual's, say, anxiety level might be during a call, but you have the ability to look at how they're doing across time, or how a population of individuals are doing, or if COPD is a problem, or if you have pulmonary tract sounds, which would be indicative of, say, the onset of flu season. So there's a range of ways to use the technology. Let me get into the case study. What we were looking at, and we did this for both general anxiety disorder and for, in this same study for depression, using the GAD-7 and the PHQ-8 as a label. Individuals in the study were then asked across time. As a screening, we combined minimum and mild and moderate and severe, which is common in the literature. And we looked at these categories. 7 questions are asked in the GAD-7. 8 questions, as many of you will know, are asked in the depression, the PHQ-8. What we found in the literature ranges, the current literature has a sensitivity for the GAD-7 of about 0.74 with specificity of about 0.54. To the label itself, the vocal analysis was 0.82 and 0.81. And against the analysis by the physician, we had similar results. In this particular study, there were 291 calls. Only 17 of them were severe, with 33 of them being moderate. In a study, we'd like to have a few more, but we have built this study out to include nearly 5,000 now. The purpose was to both explore and validate the use of vocal biomarkers on a call center data. This study has been duplicated on smart devices and smartphones as well. The call center calls extended to include oral administration of standard self-reported questionnaires. So the GAD-7 and the PHQ-8 were asked during the call, similar to what's being done in Japan. And the population size in Japan, the initial pilot size was 5,000 people. So the call recordings were then segmented from billing and also surveys. And so we had 2 separate types of calls, and then Canary Speech manually annotated the question set. So we went through and looked at the scoring from the GAD-7 and the PHQ-8 manually from the answers that were given. And then we used these labels to create a machine learning model for predicting anxiety and depression. So just to give you an idea, out of 422 total calls, 387 calls in the survey had the appropriate length of data. We held back 35 calls to do a test set against the models that were built. And then we had, and the audio that I told you was a wave, 8 kilohertz, 2-channel, so that we could separate the customer calling the patient, if you will, and the agent. And the quality of the audio was quite good. What we found was the correlation of the calls, 40 seconds. If we went for 40 seconds, which was double our goal, we had or more than 80% of them fell into that range. And we had the ability then to analyze the data. It was interesting that the annotation of the data was very, very accurate. We had it independently checked by multiple reviewers, and then we just looked at this is just standard research procedure. We found a 97.2% agreement in accuracy with a 0.95 correlation. So there was good annotation. There are some typos in the work, but those were resolved in the less than 3%. I wanted to get to the results. When you looked at it, this was kind of the population size. 54% fell into minimum, 21% fell into mild, moderate 12%, and 5% severe. This gave you an idea of the breakdown of them. This still provided us with ample data from this data set. While the data size is fairly low for machine learning, a lot of previous work had provided us with some background. The anxiety model then was based on this 25%, 20, 25% window with a sliding 10 millisecond. We look at prosodic features, linguistic features. These are all features that are sub-language level. And we use deep neural learning, deep learning to apply with machine learning. And so this provides us with then features extracted, model training, and algorithm development. We followed the literature for both of these as an assessment tool for a binary prediction. And the category prediction combined the two categories, as I've spoken about before, minimum and mild, and then moderate and severe. We also did a 3-category prediction, but we had no literature support for that, so we didn't report on that. Then we used the blind data beyond the training data. This is just some details of it, but we use what is called a 9-fold cross-validation. And from this, we have these results. Some of the early studies on the use of the GAD7 in this lighter blue had a population size of approximately the same, around 1,000. A little higher sensitivity and specificity. We found sensitivity and specificity that correlated quite well with this. And we're quite excited that we could provide a tool using an alternate type of technology. So we have an objective vocal biomarker assessment with a subjective question set, self-reported question set. Having two different sets of data with any kind of assessment is often nice to have. So this came out. Using the survey and billing, we had higher accuracy than if we split them. That's not unusual. If you split them, you have less audio, you have less data. So putting them together, we had higher predictability. This included non-telephone audio. When we looked at other models, for instance, if you took the models we built from smartphones, 16 kilohertz, and we downsized that to 8 kilohertz, technically what we do is we cut off the range. And we use that data to train. That did not improve the accuracy. So even though we had thousands of additional data sets. We retrained it as if we were starting from the beginning and added this new data to see if the resulting algorithm or model would be more accurate on the original parent data. And it turned out it wasn't. The best accuracy came from utilizing the 8 kilohertz data and building the model specifically from that, even though technically we should be able to combine them. We found keeping them separate actually improved the accuracy. So both we have pursued a path of having 2 separate models. That's transparent to the user. If audio data comes in from a smart device, it goes through the 16 kilohertz model. And if it comes in from an 8 kilohertz device, it goes through the 8 kilohertz. We tried other techniques. We found that the original approach was better. The larger the data set gets, the more tools we can apply, if you will. But we'll continue to do work. Currently, the accuracy is consistent with the current accuracy in the GAD7 and the PHQ-8. Now, just to give you a perspective over time. So let me, there was a question that came in. Let me address it before we get too far away from it. Whenever you capture audio, if you do it on a telephone, your telephone data is what's called 8 kilohertz data, meaning that the data is captured in an 8 kilohertz protocol, and the range of the data from the easiest way to describe it is tone. The range of the data spectrum is shorter. 16 kilohertz is actually double that size, but so telephone systems, as we would a home phone or a telecenter phone, is 8 kilohertz. You find it around the world that way. There are variations, but 8 kilohertz is very common across the US and in Europe and elsewhere. But when we get to smart devices, they typically capture data in 16 kilohertz, giving you a broader range of the spectrum. That additional range may have information in it that can contribute to recognizing the specificity, improving specificity, or recognizing more accurately a disease. Deep neural nets will do a very good job of accommodating for whatever type of data you give it, and create the best correlation and resulting algorithm. What we have found is that if you try to mix the data up, it doesn't improve the performance of the tool or the deep neural net and machine learning. So we keep them separated. Billing and non-billing. So billing calls with the individuals, and these were different segments of the same call, but the billing might be related. So these were not calls specific to how are you doing today or a clinical call. Conversations occur throughout a range of different types of communications that we have. And those might be intended specifically to be a call about an individual's welfare, or they may be a call that's being done to explore or answer billing questions that a person has, or do I have, if it's a call center for a medical service center, it may be a call about their illness, or it might be a call about, do I have access to this type of clinical help, and what would be the cost under my insurance for that. Now, a conversation about what my services are, what my billing might be, what my insurance covers, is a different conversation than, can you tell me how you're doing today? Now, both provide information and use different functions of the brain. An individual had the intent to ask, what insurance coverage do I have, and how much do I need to pay, and what's my deductible? They had kind of a script in their mind, and they're pursuing that in a conversation with the call center. And then the call center is talking with the individual about, how are you doing today? Now, that engages the individual in a thought pattern that is different than if they were working from a mental script, if you will, or even a written script that they might have written down. So those types of information provide a rich sense of who the person is and maybe what their condition is. I should say we have found that in cognitive assessments, asking a person to engage in kind of a thought process. Tell me what you see in a picture, for instance. You provide them with a picture and they're talking about that. That can be done more easily on a smartphone than it can be in a telephone call, of course. Describe a pattern. Tell me how you made lunch today, So they're describing a process. Some of that is interesting and more effective with cognitive assessments than simply asking them, tell me how your day is going, or engaging in a telephone call. When we did this same work in Japan, we had a concern that individuals in Japan culturally might not engage in conversation with us. Over the 5,000 individuals that we had, individuals who provided more than 40 seconds of conversation was higher than 86%. The mean, for instance, was 87.5. So the longest conversation was 2.5 minutes, and the shortest conversation was 12 seconds. So the population, fairly large population, still engaged in these conversations, because it's a natural thing to do. And it's not the first time they've called the center or the first time they've spoken with individuals from the center. I hope that's helpful to that question. Over time, machine learning improves over time. And so what you see is that accuracy and sensitivity, specificity will improve over time with more exposure, both to the population, but also to the individual. One of the things that speech offers, and it's a very interesting thing, is if you're doing regular calls with an individual, while the data that we have is de-identified, so we don't know an individual's name or identity, the audio record can be associated with previous calls. So under those circumstances, you could actually look at where a person was in their stress or anxiety level, their mood or depression, or even pulmonary sounds. So a post-discharge congestive heart failure patient where pulmonary infections could be quite dangerous, you could follow that longitudinally for the first 3 months and have a sense that they're not developing a pulmonary tract infection because of the sounds that you're hearing. Now, this can augment what the clinical team is listening for and give them a real-time alert, if you will, that should be explored. So there's a lot of opportunity to integrate the use of this type of technology into what individuals are doing in their regular day and provide them with more data to help make decisions about what the next action should be. Can this individual wait for their normal clinic visit 3 months from now, or should we move that meeting up to this week? That kind of decision making. Questions? I hope that I didn't speak too quickly for all of you.
Thanks, Henry. That was really, really great. I appreciate it very much.
Thank you.
I had some questions. Let me read off a couple of the ones we got. One was about patient consent and how the patient will be used. I think you covered that a little bit, but you want to talk for a second about that?
Sure. I think broadly speaking, and this is a complex issue, so forgive me that I break it into two pieces, but broadly speaking, you'd want to know that the systems are in place, whether you're gathering data from a blood draw at a clinic or you're capturing a blood gas or even a blood pressure measurement. You'd want to know that the data that's being collected is captured within the requirements of HIPAA medical data records security, and is handled with the confidence and respect that it should be. Canary Speech decided on its onset that it would be a member of that community. So we're audited externally every year for what's called CIS vulnerability penetration, SOC 2 type 1, and this year's SOC 2 type 2, but also HIPAA compliance. And that includes from where we capture audio to how it's handled on the web services, how it's transmitted back and forth. And so that's a very, very important element. That's kind of your foundational commitment to the community, that we're part of the healthcare program. On the other side, those standards should be audited externally from the company, which they are on an annual basis, which is what's required, but also our partners participate in audits with us. So large healthcare institutions such as Hackensack Meridian and other very large medical care institutions, if you will, we open our doors and they audit us for that, and then make suggestions on processes and other things if we need that for improvement. So that's important. It should be foundational to the company. These are medical, in how we use it, they're a component of the medical record and need to be treated as such. Okay. Now, informed consent. Everyone who participates in any type of engagement with a medical provider is provided informed consent. Vocal biomarkers is kind of the new guy on the block. And so as the new guy on the block, and by new, I mean years of use, but nonetheless still intriguing, new. It's being used in large medical institutions in various countries, but still new. And as the new guy on the block, it gets a tighter look at the haircut, you know? And so our informed consents are engaging with patients and probable participants. And so everyone is explained. And the questions that come up are, how are you capturing it? What will it be used for? How will it be stored? Who will have access to it? All of those are common within medical record data and informed consents. But it's helped us all to step up, kind of renewing our commitment to it, because the new guy on the block requires a new look. And so I have found with the institutions that I'm working with that it's allowed us to, I think, help raise the bar, and for all of us.
Thank you. There's this add-on question about use in pediatric populations. It seems like a lot of the work you've done initially is on adults, but maybe it encompass pediatric populations as well.
We do. I don't speak often about the pediatrics and the adolescent populations because of, frankly, a desire for confidentiality to them. But let me give you one example. Autism. Autism has dramatic vocal engagements. Autistic children, if caught early, can be profoundly helped by our medical profession, truly. And so what you find is that usually an adolescent, a pediatric patient is seeing, post the initial period is seeing a generalist during the time in which autistic characteristics may be presenting. A generalist, wonderful people, but not necessarily trained specifically to recognize those characteristics. If you combine that with most of our systems today, and I'm speaking with multiple ones, most of our systems have wait periods of months of time from identifying a potential need for a specialist to when they can actually schedule the specialist. And so if we can identify earlier and provide a tool at the entry level or the pediatric or generalist level, a tool that could help them identify, and which we can, then the individual can start that clock earlier. There are other things they can do to help parents address autism at home while they're waiting for, a specialist appointment. So all of those things are important. We're also looking at other pediatric, not pediatrics as much as young adult characteristics and youth. Most of our work in that area is specialized to the disease. And so if you have specific questions afterwards, I certainly would be very happy to address them.
Thank you. There's a couple questions that are about, I'm trying to phrase it right, about, it looks like you've had homogeneous populations, but I mean, you're talking about a whole country, right? Japan or other locations. And some of the questions go around this idea. Well, some of the questions ask about whether non-native English speakers, but I mean, you clearly cover other languages. But when you get heterogeneity of languages within a given population, I would imagine the model's trained for that and is accommodating to that. But I was curious to see how that works, particularly as like a care provider. If I get people whose English isn't their native language, I struggle with some of the things that maybe the machine learning process has actually been able to overcome more readily than I have.
Sure. It's a perfect question. Over the last year, as we've looked towards validating this in a more robust way, we actually took models that we had developed in different areas and said, we hired 3 different CROs from different locations within our country. We've been gathering data out of Ireland and Japan as well, and other languages. But in an effort to both for cognitive and stress, anxiety, depression, we also have a very nice energy model, which I didn't get to talk about. But at any rate, what we did was we looked at a very diverse, heterogeneous population across the US. Now, the reason, and gathered 3,000 to 5,000 labeled audios, meaning a GAD7, a PHQ-8, in a controlled environment. So we asked a professional organization, contract service provider, to capture these audios. They're well trained to do it. That's what they do for pharma, and they do it for other studies in FDA clearance and 510Ks, and that's their jobs. And so we captured data across, and in addition to having a broad population across the United States, we also looked for balance in different ethnic groups across the US, so that we could have proper representation of those different groups. Now, as you have said, machine learning, deep neural nets, this is what they were built to do. So they know what the label, we know what the label is, and you take this diverse population and you ask this system that loves big data sets, and you're giving it, in this particular case, just hundreds of millions of data points. And it begins looking at correlations, and it's considering the breadth of that diversity and looking for the best correlation, and how the model, the resulting algorithm, can best then, whether that came from a Native American speaking multiple languages, or it came from an inner city individual whose language appropriate skills may be different than a person in Boston or the South, or maybe there's a noted accent and we think, oh, does that interfere with the biomarkers? Well, we would wonder that too, and we did wonder that. And so you take this much larger data set and you ask the model and the tool set that you're using to then create the best match. And then, of course, you go back and you've held back data from each of those sets, and then you process that. We have a paper that is going to publish about that, and we're going to look at the Japanese data. And because we collected data from Osaka up to the islands north of the Main, across, and we participated in that with their National Institutes of Cerebral and Cardiovascular Health. So that was a government-focused large data gathering from across. And believe me, the accents in Osaka are significantly different than they are very north in Japan. So the question is excellent. It's one that is absolutely something that has to be considered. And one of the wonderful things about the tool sets we're using to do this is they really truly were designed to handle data sets like this. So.
Perfect. You already talked, one of the questions was about the breadth and depth of conditions. And again, if you have questions, you can submit them through the question and answer, the Q&A box in the bottom. You can submit anonymously, or you can put your name on them. Well, one of the things I'm curious about is being able to discuss a little bit about the population health implications of your work. And you work in populations, right? You're already engaged in those situations, but in a country with a very fractured healthcare system, where CDC has a lot of responsibility to try to improve across large populations. I was wondering if you had thoughts about the applications, both. So I think that there's two questions there. Applications in the population health realm. I'm going to stop there, and then I'll let you answer, and then I have some other questions about that.
Sure. So what's nice about this is it's deployable on the smartphone. It's deployable with a link. So you can design a specific app. Say you wanted to collect data in Cleveland, Ohio, and you could submit. You could engage individuals with an invitation to do a question set and an audio on a smart app. We have a configurable app that can be used to do this. Others do too. But that allows you then to invite individuals. They can then open a link which would bring the app directly to them with the credentials to complete an anonymous de-identified assessment. It can be designed to provide them with the results of that assessment or just to thank them for participating. But in doing that, and we've done this, individuals within a community can provide responses, and you can then get an understanding of for instance, with some of the healthcare institutions we're working with, they were very interested in their employee levels of anxiety and stress. Now, they wanted confidentiality for their employees, but many of them had as many as 25 different locations. So they engaged their employees under confidentiality. They could get the assessment and help manage that, use it as biofeedback to manage their own. We could provide them with information depending on where their range of anxiety, depression was. But then they would identify only the facility they were in. So now the institution had an understanding of where the stress and anxiety levels were, depression levels were within those facilities. And if they were moving longitudinally over time to be worse, they saw hotspots that they could then go and address. Now, this would be true of pulmonary sounds or other things that could address, influenza or other diseases that may be coming into a community, but not yet in another site. So that kind of population assessments can be conducted using smart devices and completely in an anonymous, confidential way.
There's been some nascent work that CDC's been involved with that looks like de-identified searches for gastrointestinal illness medications, and then the participants' visitation in the past, I think, 6 or 10 days to different restaurants and restaurant inspection scores. But I never even thought about the idea of coming into being able to look at speech as almost one would call it like syndromic surveillance for disease around the country. So being able to hear at the most, your work is much more granular, but somebody coughing, and you suddenly hear of these calls, 5,000 people coughing or 10,000 people coughing, in a certain location, then you have some sort of indicator. And I think your work is much more granular than that. Interesting. I have another question if you still.
Please.
So then one of the next questions, and within the bounds of proprietary for the company's interest, is looking at the idea of an indicator in therapy, and not necessarily in a diagnostic realm, but then this idea, there's been some nascent work in the telehealth literature that looks at forget what it's called, but like this voice recognition devices in people's homes, and then as therapeutic interventions that are automated for people that are experiencing depression, anxiety, those sort of things. Within the bounds of where your company's going and all those things, do you think that I would think there is a role for Canary in this feedback cycle of being able to understand a problem and then direct even automated resources towards helping people, particularly elderly populations or any population really experiencing depression or anxiety, towards more engagement, sort of this AI version of therapy, if one will.
And that's accurate. Canary's working with 3 of the largest providers for elder care, where they have some kind of listening, some kind of the interactive device, and the device may provide them with prescription aid, or can you call my daughter, or other things, but all of those are audio. And so Canary's running in the background, and of course with permissions, with an understanding. But what we're really looking for there are indications. If Mary is talking to the device on Monday and she's talking next Monday, and we hear, as you and I were talking about, a higher level of depression, then we want to identify that as a potential need. We may also send an alert to a daughter or to a caregiver, or if they're within a facility, to the staff, that there's an indication of that. One of the models we're working on is a frailty model, where an indication that an individual is predictive analytics is more likely to stumble and fall. It's one of the #1 causes of decline of our elderly. They break a shoulder, a hip, an arm, and recovery is very difficult and often starts a downward spiral for them. So if we can recognize that early and try to help them, if they're more tired, if the energy in their voice is low, all of these things can be non-diagnostic, but very important in understanding future actions with them, interventions with them, care needs that we might not have recognized. So those types of things, I think, and that's in fact what the Japanese are looking at almost right now. It's one of the main things. We're working with a remote population in Ireland. We're working with Ulster Hospital and Belfast University, where they have a population that travels, and we call them border population now. They're between Northern and Southern Ireland, and they're a population of 15 to 25,000 people, and they don't have any set healthcare, and they move around, but they all have smartphones. And so in that particular case, we're interfacing with them, and their older population is not very trusting of anything. So they don't like to engage, but they'll talk to their cell phone, and that connects them then to a caregiver, potentially to Ulster University or the hospital. So at any rate, you see those types of applications, and care facilities, at home, aging better, all those types of things. And we're trying to use voice because it's an easier interface, and it's advanced enough. It recognizes, I wish I had a book on this, and it understands that, can alert someone or even ship you a book on that, So we're augmenting that experience by adding analytics on their health.
And I would imagine that vocal biomarkers given its history, it has such a widespread application beyond, probably beyond healthcare, right? Where you're talking about marketing or other things, commercial activities where you're trying to market a product or interact in some way. So I imagine the literature is quite rich. I'm just not familiar with it. It's pretty fascinating.
Yeah, the literature is rich. It's an area that we keep ourselves pretty focused on the healthcare aspects of this. Voice recognition, people ask, can you recognize who you're talking to? And no, we can't, because we don't collect the foundational information necessary to do that. We were in a pharma study once where these are very controlled. And so the mother needed to go on vacation in the middle of the study, so she handed over the responsibility to her daughter. In that particular case, we knew it wasn't her. So we alerted the staff, and they got her back. When she got back from vacation, she had to complete her round of questions. But we didn't know who that was. We just knew it wasn't the same person, So simple things like that, we will know we're talking with Mary in her home, or that it's Mary's daughter that's there. We'll know the difference between that, but we're not going to know I'm using Mary as a name, but we don't know who Mary is.
And then one of the areas, this will be the last question, I promise, is what are the boundaries of it? And you talked a little bit about, I think one of the most interesting parts of AI is understanding the implications or the actions that the process is aimed towards, and its applications in populations that are uneven, not even anticipated at the time.
Mm-hmm.
But I think I'm not phrasing it quite right, but really not the really limitations per se, because it seems like the limitations there's not much limitations to the limitations really for automatic speech recognition.
Well, the
applications and places it should be used and places where it's not as good of a use.
So there are certain things that this approach is just good at. Let me give an example. When you're doing a post-discharge patient and you're interested over the next 3 months, if recovery occurs in that 3 months, it's sustainable, and we're always looking for that. And so one of the things that, and we talked about pulmonary tract sounds, or even if we're congestive heart failure, we're looking at things associated with the recovery of the individual who had surgery for congestive heart failure. So that might be stress, anxiety, it might be tiredness, but vocal pattern changes, which have been documented to be an early warning of a future heart attack or even a stroke. Noting that, or being able to recognize that their vocal patterns are changing from call 1 to call 2 to call 3 is difficult for the individual, unless they're quite severe changes, because in between the call with Mary on Monday and Mary on Thursday, the person might speak to 25 or 30 or 40 other people. And so that for them, that's noise. And they have all this other noise, and they're trying to differentiate between all that noise and Mary's subtle changes. And what I like to tell people is this technology is not good at that. It's perfect at that. And the reason it's perfect at it is it doesn't have any of that noise. If we're engaged with a client, a hospital, or others that are supporting post-discharge, we can listen to Mary's current call and compare the vocal patterns directly in real time and create a delta and do an alert. So in that case, this tool set provides very valuable information to the person whose experience and training is making decisions about their care. And that alert isn't dictating what to do. It's providing additional information towards a decision. But that information could be critical for them. And so when you're comparing data, you can eliminate all the noise from any other conversations that may have clouded your sensories in the last 3 or 4 days. If you're looking for very subtle changes, machine learning can be very, very good at that. A well-trained physician like yourself, years of experience, hundreds, thousands, tens of thousands of patients, you have a well-trained deep neural net, but not everyone does. And so providing that kind of tool is both feedback for the clinician and seeing that data, because they've just heard something and they see what the machine learning thinks, and they can calibrate against that, accept it, not accept it, but calibrate, and may improve their learning process, but also it provides information that can augment a decision that they're making. So that's really, I think, where the tool is very helpful.
And I think the longer I practice, the more I appreciate the people or patients that I see on a repeated basis, because I understand a lot more. It's maybe a richer neural network, if one will, about that patient, all the different things you collect as far as the 5 senses.
Yeah, exactly.
What about applications where it's not, you don't think it's going to work very well? Certainly anything visual like derm or those sort of areas.
Yeah. So generally, you know, in the research that I was in the nervous system, you know, neurological diseases. I personally feel that those are kind of the rich source of connection. So things that are impacted, for instance, congestive heart failure, I would not, although there's been a couple of papers on it, its application to identifying or predicting future heart disease is machine learning at its very best. But it's machine learning, not the application of medicine to deep neural nets, in my opinion. Although I've been wrong about a lot of things, so I could be wrong about that too. So when we look at congestive heart failure, we look at the associated things like stress, anxiety, tiredness. Is the patient recovering? Now, stroke has direct implications to whether or not we can, if it's in the speech center, it impacts directly on our speech. If it creates paralysis in a part of the motor function that creates language, it's there. So not only could we see speech recognizing early signs of stroke, but also potentially identifying what area of the brain the stroke has occurred in, because what area of the motor processing or the neural system has been damaged, and what elements do we see changed in the speech. So I think in those cases where there's a direct implication, Alzheimer's, Parkinson's, Huntington's disease, any of the ones that are central nervous system relative, MS, those types of things, all of these have implications which we listen to. You know, we hear them. If we can hear them, we can model them, you know, and if we can model them, then we can create a standard by which we're then measuring them and then augmenting that with the individual, the clinician's personal experience with the disease. And so it's a tool for them, you know, just like a stethoscope is a tool, or a blood cuff. Maybe it's a more elaborate tool, maybe it's a more complex tool, or maybe, I don't think it's that more complex, but you know, maybe it has more intricacy to it. I don't want to undersell what we're doing, but at the same time, we should think of it as a tool to assist in the process of evaluating a person.
And I really liked the author you talked about and the natural language processing that occurred.
Agatha Christie.
And being able to look at even the collections of phrases or over time, and how that was very correlated with the progression of Alzheimer's, which was really amazing. I think natural language processing is really opens up. It's almost like finding new oil, if one will, in medical records, because you just have such a wide range of capabilities now to go through. Or hopefully, handwritten records aren't off the radar, but the typed records, it just opens a whole new realm.
No, I agree completely. It's a fascinating area, as I said, and I think they're often when we worry about one area or the other, that's so good for us to be doing. Like we were talking about confidentiality and informed consent. If there's something that causes us to focus our attention again on the patient's requirements and legitimate need for those things, if there's a reason to do that, that's good for all of us. And so I just welcome that. I can't even tell you how many organizations whose legal teams I have been with, wordsmithing things. And at the end of the day, the dignity that we're retaining for the patient that we're caring for, that's what we're doing, through that process. So very, very healthy.
Excellent.
Mhm.
I feel I've peppered you with a number of questions, and I very much appreciate your time. Did you have anything you wanted to close with?
No, I would say, speech has been around now for 35 plus years, where we really have been working on it. And from some of the slides I showed, it's been a progressive development across time. That progression has allowed us, both on a technology platform, where it's really accelerated in its capacity to analyze data and the speed at which it does it, and our understanding of the tool set. It's allowed us now to be at a position during these last number of years to make a difference, I think, in healthcare. And there's excitement around the world to do so. And I think the benefits could be amazing. So I'm glad to be, thank you for the opportunity to talk. I really appreciate it.
Well, thank you for coming and taking the time. Very much appreciate it, Henry.
Mm-hmm. Same here. Thank you.
We'll close out. Our next lecture will be October 5th, the first Wednesday of the month, and we'll be talking about legal epidemiology. So always love the variety of topics we have, and very much appreciate the audience. We will see you around next time. Thanks, everyone, and take care. Stay strong in the upcoming month.
You too. Thank you. Thank you so much.
Thanks, Henry.
Please take care. Let's stay in